everyone, and welcome, and great to have you here. We're on the right slides, that's good. Just a very quick brief about the Australian healthcare system. For those that don't know, we are a federated system. We have hospitals, acute hospitals funded by states, and we have the Commonwealth Fund. They fund primary care and a lot of aged care. So we have sort of like a two-tiered level system. It'll start to make sense when I start talking. So what did we do and why did we have to do it? I'm the Director of Integrated Care at the Mater Health Services in Brisbane, and that's a number of public and private hospitals, both adult and maternity. And one of the things that we were experiencing was a huge increase in the number of presentations in predominantly over 75-year-olds in a 12-month period leading up to why we did this project. That's over 75-year-olds. In Indigenous people, we actually treat it as over 55. The expectancy of our Indigenous people is a lot less, something that we still need to work on. So why did we do it? Well, evidence does tell us that older people are at increased risk of suffering harm and poor outcomes as a result of a hospital visit. They have greater disability, they end up with falls, delirium, medical errors, acute illness, polypharmacy, you name it, we've got it. There's also evidence to say that hospital clinicians are spending more and more time and more resources on providing care to this very complex group of people. And also, frail older people the evidence has shown that they do respond well to rapid specialised emergency department based assessment to predict frailty and adverse outcomes. And we weren't doing that. People were coming in as normal to the ED and we were just going through the normal process. And consequently, they were predominantly being admitted and they were at risk of those adverse outcomes. So that was the problem. So what did we aim to do? We wanted to really look at what the problem was because we didn't have the data to say what our prevalence of frailty in ED was. We used the Rockwood Clinical Frailty Scale. There are many other frailty scales, and I'm not saying you should use this one, but that's just the one that we used, and we adapted it to fit our purpose. And we just wanted one tool that we could use both within the ED, within the acute system, and also, in our case, within aged care facilities, because we got them on board to look at when people were entering aged care facilities in our area where they were on the frailty scale. The population data related to Mater's older population, also in relation to not just where they were on the frailty, but their social situations, the geriatric syndromes and what they presented with and what their utilisation of healthcare was. And we also wanted data on the effects of the particular team that we were going to implement to guide further development of pathways in the future. This is a very busy slide, you don't have to understand too much. It was really just to say this has happened over a period of time. We started in 2014 with what we call MACE, the Mater Aged Care in an Emergency. That was one FTE nurse, who was amazing. And we really, at that time with one FTE, we just saw people coming in from aged care. By essence, people in aged care in our area in Australia are all frail. People used to go into aged care and be there for about 2.5 to 3 years. Now that's at about 18 months. They're getting older and frail when they enter aged care, and so by definition, when they are there, they all fit the frailty scale, unfortunately, but they do. So we had one FTE, we did the project for 12 months, we got a little bit of extra resources, and then we produced the paper, which you've got the reference for up there. And that was the outcomes of MACE, which I'll go through in a minute and tell you a bit about the team. What happened in 2017, we got an additional contract to do some additional work from another health area, particularly around presentations to ED. In our normal ED, presentations, about 23% of them were older and frail. In the new activity that we got, 80% of the presentations were older and frail. And I think without MACE having started, it really would have been impossible. But we saw what was happening and we said, well, this is a huge increase of people coming in at the front door. How are we going to deal with this? So we actually merged a number of other teams that were operating throughout the health service, that were on the ward, that were already in ED with our team. We also have a domiciliary multidisciplinary team, Mater at Home, which is medical nursing and allied health that go out into the homes or into aged care facilities to provide care. So we tried to create a pathway that incorporated all of those and bring it all together. And really what we were looking at is, could we amalgamate and redesign these resources and reduce duplication and close the care gaps that we thought existed? So that was sort of the journey that we've been on, and this is sort of where we're at. So I developed, my interest is really trying to look at the health system and looking at a governance for a health system. And the systematic review identified 10 key elements that we really need to address across the health system. This is primary, acute, social, whatever. But if you're looking at a population, what are the things that we need to do? Those, I put it into a balanced scorecard, and the reference is there for the systematic review. But these were the 10 elements that were described. I'm not going to go through those in detail here, because that's not what this is about, but we're doing a workshop tomorrow, and I'll go through more detail about the 10 elements. The two that were in yellow, or orange, are the information communication technology to share information. We don't have a shared electronic health record in Australia. Well, they're trying to have one, but we haven't got one yet. So we did have a shared resource. We had a book that went with patients, that followed patients, but we don't have that. And that was why that's in orange, because we're not quite there yet, although we did do some things to help improve information exchange between the multiple providers. And we also have a funding model which is very much, you're either in hospital and it's activity-based funding, or you're in primary care and it's fee-for-service. So our funding model does make it problematic to do this work, but that didn't stop us doing it. So who was the team? So these were for patients. Those are the eligibility criteria. As I said, it's for older persons 75 years and older, but if people were Indigenous, that was lower. I think the rest speaks for itself. I think people would probably know what the eligibility criteria are for the frail and elderly. I don't need to go through those. The team primarily was clinical nurses in ED. These aren't emergency trained nurses. These are nurses who have worked in the community, they have worked in primary care, some of them have worked in wards in hospitals, but they come with knowledge about what the community and primary care can offer, and that is really important. From two reasons. One, the ED nurses initially resisted it because they're not emergency trained, but also because their focus very much is on the whole care of the patient and the continuum of care, not just about managing an acute presentation when they present. We have a social worker, we have a pharmacist who's based in ED, an educator, and we also have some research time. So the outcome so far, that's really just to show you what our problem was. So the increase in people who are coming to ED, this is just our ED, it's increasing and it's continuing to increase. The clinical frailty score, this was the outcomes of the people who are coming to our ED. Now the important thing to note here, a bit behind, is the orange box here is those who are vulnerable and at risk. The ones here are independent, they're the ones, all the older people who are doing the normal thing, well, generally don't have too many problems. These ones are the ones at risk in the orange, and this group here, this half, are that group. So you kind of go down the scales from vulnerable, mildly frail to moderately frail. And then the end ones, which are really those in aged care facilities who are palliative end of life, very, very frail. And this is this half of that population. The interesting bit for us was this 35% here, who are moderately frail, because what we're not doing is we're not identifying those until they're coming to the ED, and we're not actually looking at how we identify them prior to that, because they're not in aged care facilities, they are generally in the community. And this is something that we're now looking at and working with our primary care organisations. We have primary health networks, which are our primary healthcare organisations, and our primary care providers, GPs and practices, to look at how we actually identify those before they actually start having problems. So the outcomes so far, as I said, 35% are classed as moderately frail, and the first time they pretty much have any problem is when we see them in emergency, which I think is a failure of the system. I think 55% of them have a cognitive impairment, and 100% of those 55 are at risk of a delirium, falls and pressure injury. They're a high-risk population. Nearly 50% had no appointed decision maker, and that's a huge problem when you're getting people in with cognitive impairment who are older and frail. The impact that has on them and on their journey is significant. They end up getting in hospital, they're stuck, and to make decisions becomes very difficult, and it's not often a very good if it is an end of life. It's very protracted and very painful. 80% of them already receive care and 30% of them live alone. 40% of the patients who came to the emergency department were seen by the older person team. Not everybody who comes to an emergency department are old or frail and need to see them. So of the total population, and that's still a significant population for 3.4 nurses to see, the average time spent was an hour. 80% of the 40% that were seen returned home from ED and short stay unit. Previously, probably more than half of that, probably near about 2/3, would have been admitted to hospital. So that's really significant. And the idea being that these nurses and pharmacists, allied health, they actually work with the community, with the ambulance, the primary care physicians, the aged care facilities to look at when they're first coming in. The GPs now phone saying, I'm sending them in, this is the background, this is the collateral information, as we say. They're actually telling us what the problems are so that if we can proactively try and plan for them to go back out. And as an example, if someone's on warfarin and they've had a fall and they need to have an X-ray, we don't, but there is a mobile X-ray service, but you have to pay for that, and not everybody can do that. So, but if we know they can come in and they can then, they actually don't go to ED, the best is 7 minutes. We've had them come in, go straight to X-ray, have the report done and go back again. Because we know from evidence that the less time that they spend anywhere near an acute facility, if there's no other reason, it's best. Because we start testing, we find so many things wrong with them, they're admitted, and then it all cascades from there. We've had a 220% increase in referrals to our Martyr at Home, which is really our multidisciplinary team. We have physios, OT, speech therapists and a social worker, as well as an infectious disease physician. They also do hospital in the home, but these really aren't on that programme. There's been a 19% in hospital admission rates. Our representation rates of this population aren't any greater than the rest of the population that would represent. It's the same percent, because people keep saying, oh, they'll come back more. They're not coming back more, it's just the same. And redistributing what were ward-based services into this team, which goes across ward and ED, hasn't made any difference to the outcomes on the ward, but front-ending it has had a significant impact on managing these patients. So the lessons learned. So there has been an increase in total presentations of this population over the last number of years. The majority are severely or moderately frail, and they are very much at high risk of hospital-related harm should they not return home if they're able to. I'm not saying not everyone should go home. Some of them are admitted, but for those who can go home, they should. We have been able to show that having this particular team based in ED, but really truly linked with the community. We have a working group which has GPs, the ambulance, some hospital physicians and nurses. We have a consumers, aged care facilities. I can't remember, it's about 30 people. But it's actually the whole of anyone we can think of that wants to come in, they can come in. Our primary health networks to look at how we use our resources more efficiently. And it has an impact. We use the quadruple aim to measure. The Macy showed a 10-to-1 cost benefit. We've had an improvement in the various clinical outcomes. We've got staff satisfaction improved. It's very difficult to measure patient satisfaction because so many of them have a cognitive impairment. So we've actually basically looked at and worked with families and got their impressions of their satisfaction, because really a lot of these decisions are being made on behalf of these people by their families. Assessing frailty at the front door is amazing for patients. It really puts the focus on what is it that these patients want. And I think, we say it's like having a crystal ball. It's being able to assess very quickly those who are at risk of poor outcomes, who can and are safe to go home, with communication from all the other providers that they would normally have access to, is absolutely gold. It really is. I've been quite surprised, even myself, by the outcomes that we've had. Some patients will return, some patients always return. We can't stop that happening. That's kind of part of the course, but they're not returning at any greater rate than any other part of the population. The most powerful weapon that we've had in trying to do this and do this change has been data. The clinical nurse who runs this, when she first started, she was the one FTE. She said, I'm doing nursing. And I don't like data because I'm just doing what I like doing. 3 years later, she's going, I really haven't got time for nursing because I've got to do the data. Because at the end of the day, when we've had to stand up in front of the board or funders or, researchers or anyone else, having the data and having narratives, I think the previous presentation and someone else this morning talked about the use of the narrative, and having narratives about what the experience has been like from the family and the carers and the person's perspective just is incredible. We presented to the board and I put up a couple of journeys and a narrative from a particular journey. And, we had the 10-to-1 cost benefit, we had the improved clinical outcomes, we had all the great things. And then I showed these two, they said, well, that's very nice, but, you can't have any more money. So I said, well, this is the journey of two journeys that we have. And they said, oh, well, that wouldn't happen here. I said, no, that was 3 weeks ago, and that was 2 days ago. And they go, well, that's awful. So, the power of the journey and the narrative cannot be underestimated. So I could just leave now and say, we've done a great job, all right? But as the title suggests, it wasn't all that easy, and it doesn't continue to be easy. For all of the good things that have happened and all of the great things, you've all seen the culture triangle, I'm sure. So it is person-centred. We did have a vision. We had collaboration and partnerships from everyone that we could possibly think of, including the consumer voice, or carers in this case. It was clinically led by multidisciplinary teams from both primary care and the hospital. We are dealing with a complex system, and we know that, so we try to be collaborative and have the partnerships that we thought we needed. It is about changing the behaviours and practices, and in many ways we have done that in some areas. Like I said, within ED, the nurses now are a fundamental part of it. Primarily the ED director, who initially trained as a physio, then worked as a GP, is now an ED physician. He's fantastic. He understands the various parts of the system, and his leadership has been fantastic. But even getting the buy-in from the new registrars or the interns, the various members of nursing staff, has taken time, but we've got there. However, there's a lot that lies beneath, and I guess this is the final slide, but it's really what I wanted to say, is that all of this is about people and culture. Whilst it's primarily for me about the patient and about the outcomes for patients, but the change is about people and culture. And to try and align those with all of those things that lie beneath the triangle is something that, 4 years later, and I thought we've done a good job, I can now, as I do as a Director of Integrated Care, do something, change it, and it moves into normal practice, thinking, oh, my job's done, I can move it. Yet there is still the rub between all these different things. So we talk about inter-organisational, interprofessional education. We do that. But it's intra-professional as well. It's between, the GP, the ED doctor, the general physician, the geriatrician. Everyone thinks that they kind of know what's best for these people. It's between the nurses in ED, the nurses on the ward, the nurses in the community. It's all about, well, we can do this here and we can do that there. And it's very easy, not easy, but it continues that unless you have this particular team, in our case, as the glue really that holds it together and focused on that continuum of care. It's the way we're trained in Australia, it's the way we're funded. We are funded to have people admitted, and the community is fee for service. They're funded to see people. So when we're saying we can stop people coming in because it's good for them, as a general physician has said to me, but I'm going to stop my funding stream. So we can prove that it works, we can prove that it's great for patients, but to get hearts and minds across the board, it really does come down to leadership. We need, in our case, the boards, the senior clinicians at all levels to really say that, no, we understand that and there's still plenty of work, but this is better for this patient group. And it takes a bit to stand up and say that when you've got some quite powerful people in the room saying it's not. It takes a degree of trust. Our aged care facilities do a great job, and yet they do get hammered a little bit about sometimes the care that they provide. They often don't have the same level of staffing that other places have, and access to a lot of other multidisciplinary parts of the team. But they have come so far with us. When we first started 5-6 years ago, that were coming into the MATA had an advanced care plan. Now 88% of them do. Many of our aged care facilities have stipulated that when people go to their facility that they have to have an advanced care plan as part of going there, which makes their care and those early conversations with their carers and family a lot easier to have. We do interdisciplinary and multidisciplinary education and training, both with primary care and the acute care system across the region. But really, we try to align KPIs and incentives that we can affect, but we cannot affect all of those, and we can't change the fact that hospitals get paid for activity. But we have tried to say, whilst that's not what we're about, but we do look at those other KPIs, we're really about the patient and about what their outcome should be. That's it. Thank you.
Yeah, so we